as answered as possible. We're going to start the meeting. So my name is Arjun Singh. I'm a first-year medical student and an officer for the Bioethics and Humanities student group. Just a couple of items for the student group that I'd like to mention. There are two classes being offered, two evening classes that are remote and asynchronous. One of them is the Global Health Humanities, and then the other one is Introduction to Public Health Ethics. And both of those are through the Center for Bioethics and Humanities. Another event that I'd like to introduce is on Thursday, October 17th. We are bringing in Leonard Bernstein, who is a psychologist and trained pianist, and he does a series where he does concert lectures. So part of it will be introducing various psychologists and philosophies, and then he will also be playing the piano as well. So that will be on Thursday, October 17th at 7 p.m. I believe here in the, okay, at 2 South. And then the last one, the Bioethics and Humanities student group is taking somewhat of a hiatus over the summer. And then we will be kicking off our new school year on September 9th, 2024. So that'll be the first Bioethics Humanities student group meeting for the new school year. And with that, we'll get started. Before I introduce the panelists, I just want to give a brief background and discussion about CRISPR technology and what prompted this event today. So CRISPR technology can be dated back to first being researched in the 1980s, the late 1980s, when researchers in Japan found that there were short, regularly clustered interspace repeats that were found on genomes of E. coli bacteria. This wasn't completely understood on what they did or why they were there until about 10 years later in 1995, when researchers found sequences of foreign DNA along with these CRISPR sequences in bacterial DNA, suggesting that CRISPR had some sort of copy and paste function. And that was the first time that people started thinking that this was a technology that used to edit genomes, essentially. The actual experimentation of the mechanism of this new technology wasn't actually done until the early 2000s. And the first thing that was researched was the Cas proteins. Cas9 is the prominent one that is associated with CRISPR, so CRISPR-Cas9. Essentially, this is a endonuclease, so it's the actual scissors of the genome scissor apparatus that is CRISPR. A couple more discoveries were made in the early 2010s, mostly stabilizing proteins that were necessary for CRISPR function. And then after these were found in 2010, that was essentially all the various components of the CRISPR-Cas9 system that we know today. And it kind of completed the puzzle of this gene editing technology. And these discoveries were actually led to the awarding of the Nobel Prize in Chemistry in 2020 to Jennifer Doudna and Emmanuel Charpentier for their discoveries in CRISPR. So in the 2010s, after these, all these various components came together, kind of the race was on to implement this technology and to research more with animal and human models. The upside was very apparent. The technology potentially to cure heritable diseases, very, deadly diseases that nobody could really get a handle on up until this point. But the ethical discussions surrounding this technology were equally as prominent, equally as important, if not more important. Where's the line between appropriate and inappropriate uses of gene therapy, and who gets to draw that line? This was heavily debated in the 2010s, but it was generally agreed upon that the safety and scope of use of this technology was not understood well enough to implement this into clinical applications. This was up until November of 2018, when, and excuse my enunciation, Zheng He announced the birth of twins that underwent CRISPR-Cas9 gene modification for the first time in China. This was the first of its kind, the first births using this CRISPR-Cas9 technology, and it was heavily scrutinized by the scientific community, especially the committee surrounding CRISPR-Cas9 technology and the ethics surrounding that. And in the actual experiment, or in the birth of these twins, what this researcher in China was accomplishing was to provide HIV resistance to these twins, which apparently did so successfully, but still sparked a lot of outrage and claims of being inappropriate and unjustified. So, and that leads us to the events that took place to kind of spur this talk, which were last year in December. CRISPR-Cas9 gene therapy became FDA approved for the use of sickle cell anemia. And in May of this year, the first patient in the United States, a 12-year-old boy in Washington, D.C., began the first gene therapy using CRISPR-Cas9 for sickle cell anemia. So that's just a brief background. That's definitely not comprehensive background of CRISPR-Cas9. But I would now like to turn it over to our panelists and introduce them. So on the far left here is Dr. Christopher McKinney, who is an associate professor in the Department of Pediatrics at the University of Colorado Anschutz Medical Campus. He's the director of the Pediatric Sickle Cell and Hemoglobinopathy Program at Children's Hospital Colorado. His clinical and research interests center around expanding curative and transformative treatment options for patients with disorders of beta globin. He has served as institutional principal investigator for several transplant and gene therapy trials for patients with sickle cell disease, and started the clinical gene therapy program for patients with beta globin disorders. In the middle here is Dr. Curtis Coughlin. He is an associate professor of pediatrics at the University of Colorado Anschutz Medical Campus. He received his master's of genetic counseling at Arcadia University, his master's of bioethics at University of Pennsylvania, and his PhD at the University of Colorado under the mentorship of Professor Stephen Goodman. Dr. Coughlin is an ethics, legal, and social implications of genomics researcher, and his publications have focused on equitable access to genomic information, return of genetic results, omics, and privacy and individual decision-making. He has also served as the ethics content expert for the ClinGen Consent and Disclosure Recommendation Work Group, Colorado Department of Public Health and Environment's Newborn Screening Program, and the National Society of Genetic Counselors. He also services as healthcare ethics consultant at the Children's Hospital of Colorado. And then last but not least, on the far right there is Dr. Lindsay Brubaker. She's a gynecologic oncologist here at the University of Colorado. She did undergraduate and medical school at George Washington in Washington, D.C., and then OBGYN residency at Stanford. She moved to Colorado for fellowship in gynecologic oncology and is now a member of the gynecologic oncology faculty. She is 80% clinical, so she does surgery and chemotherapy for the gynecologic oncology patients that she sees. And then she has a research program focused on platinum-resident ovarian cancer. All of her work with CRISPR-Cas9 has been preclinical / translational, so only in the cell lines working with, so preclinical research. She recently received a $1.1 million grant from the Department of Defense for ovarian cancer research. And please join me in welcoming our three panelists today. Okay, so we'll just kick off some questions. So essentially I'll ask some questions until about 12:30, and then we'll open it up to any questions that the audience has. And then if anybody over Zoom also has questions, go ahead and throw them in the chat at that time. So first question, could you just reintroduce yourself and tell us a little bit about what you do and describe your current or past interactions with CRISPR technology?
So my name is Chris McKinney, and as he said, I direct our pediatric sickle cell program. I have been running gene therapy trials at the Children's Hospital since about 2018, starting with lentiviral vector-based gene therapies in 2018, and then moving on to CRISPR-based gene therapies in 2020. We have treated 4 patients with sickle cell disease with CRISPR-based therapy since that time on clinical research trials. And then we have received qualified treatment center designation to treat patients clinically with the FDA-approved products. So the lentiviral vector-based therapies we are currently open for, and starting in August, we anticipate being able to provide the CRISPR-based therapies as standard of care options off clinical trial.
Everyone, I'm Curtis. Was such a long but great introduction. I wish my parents were here to hear that. But as he said, I'm one of the clinical bioethicists at the Children's Hospital. I think that's one of the main reasons I'm here. Our job is really to help provide an ethical framework for clinical decision-making. It means we're also involved in some of the policies about expensive drugs and rare disease therapeutic trials at the hospital. I'm also trained in genetics, and my academic ethics genetics work really is focused on genetic technologies and sort of the equitable approach to the use of genetic technologies and equitable access to sort of expensive, rare therapeutics. And then my research lab is very translational. We are focused on a lot of different gene editing approaches to really rare pediatric diseases. So use CRISPR in both sort of animal models, but also designing some new therapeutics that look like they're about to go to a phase 1 clinical trial.
So I'm Lindsay Brubaker. I am a gynecologic oncologist. When I came to Colorado for fellowship, my first year of fellowship was all a translational year in the lab with one of my colleagues and mentors, Dr. Benjamin Bittler. And as part of that, we did a whole genome-wide CRISPR-Cas9 knockout screen to evaluate the difference in genetic drivers between 2 kind of groups of high-grade serous, which is the most common type of ovarian cancer, but high-grade serous cell lines in different conditions. And so we were trying to see what allowed high-grade serous cells to be able to survive after they've broken off the ovary or fallopian tube. And so it was what you consider like an unbiased genome-wide screen using CRISPR-Cas9 technology. So that was back in 2017 to 2019. And through that, we identified a number of targets that we can use to try to limit that progression of disease. And then since then, we've also used CRISPR-Cas9 in the setting of, we've since developed more focus on a particular target known as chromobox2, which is part of the polycomb repressor complex, and we have found is an individual driver of ovarian cancer. And we use the CRISPR-Cas9 technology to knock out CBX2 so that we know what happens if there is no CBX2 expressed. And so all of our work is very much preclinical and translational, but building the groundwork so that, you know, if we can show that we can really knock out a particular protein, then maybe if we can develop an inhibitor for it, we could bring that to clinical trial. So our work is less, genome editing within a given patient, but rather using it in the preclinical setting to set us up for success in clinical trial development.
Okay, so to build off of that, and this may be a very broad question, but could you touch on some of the ethical concerns or discussions that are commonly taking place in your space, whether that's clinical application of this technology or research?
I'll start and then I'll let you clean up. So I'm going to just be speaking from a sickle cell standpoint, but our major ethical issues are access to the therapies and then sterilization that is required to receive the therapies. So from an access issue, this is a very broad issue. So starting out, there are about 100,000 people in the United States who have sickle cell disease. However, there are about 100,000 people born per year in Africa with sickle cell disease. And so the treatments being available here in the United States represents only a small fraction of all the patients who potentially would be benefiting from this therapy. The second issue is that it is expensive. It costs, $2 to $3 million for a single infusion for this, which means that broad access to this type of therapy is going to be limited based on finances, and I'll maybe let you talk about that a little bit more. Third, even if you have a payer who is going to pay for this therapy, there are only certain centers geographically which can do this, and they are scattered across the United States, but this is something that potentially patients would have to travel long distances for, and this is particularly problematic for a patient population which has historically been disadvantaged and under-resourced. And so when we are battling a lot of social determinants of health, that makes it a lot harder for us to broadly offer this therapy. Even if they are able to travel for this and it is covered by their insurance, there is limited manufacturing capacity for these therapies. For some of the therapies, they are able to make one product per week for the entire country. So that means that there are long wait lists of patients who have to, basically get in line in order to receive this therapy because they can only make one product per week. And so the need for increased manufacturing capacity is quite evident. And then even if you are able to get in line to receive this therapy, one of the other major issues that we struggle with is that we still have to give them myeloablative conditioning therapy, so high-dose alkylators like busulfan, in order to eradicate their previous stem cells to make space for the new stem cells, which is going to cause these patients to be infertile. And so a lot of the patients that we are talking about treating are potentially going to be under the age of 18 before they are able to consent to that sterilization. And most of the time, insurance companies are not providing fertility preservation coverage for these patients, especially if they have government-sponsored healthcare. And then the last thing that I will say, which is specific and unique to Colorado a little bit, is that age is going to be a major issue. So we have a pediatric center, which is designated a qualified treatment center, which means we can provide this treatment to pediatric patients under the age of 21. Adult patients, however, are going to have to travel to a different center in a different state in order to access this therapy because UC Health does not have the experience to offer this type of therapy. And then the state of Colorado Medicaid will reimburse pediatric patients at about 100% of the wholesale acquisition cost of this $3 million drug, but they will only reimburse adult patients about 97%, which means that we will lose about $100,000 per patient if we treat them as an adult, at our hospital, which is not really a feasible loss that we can take, or we can't scale that loss. So those are some of the ethical issues that we have been encountering as we've been operationalizing this.
Did an amazing job discussing the ethical issues. I think really highlighting sort of the inequity about who gets access to these therapies is something that we should talk about over and over again. We should start with it and end with it because it's such a big issue. The payer cost is real. I like that you said Medicaid would reimburse us 100% for this $3 million drug, and that really helps us as a healthcare system. But Medicaid is not this like open bank that has an unlimited amount of money. So for 2 or 3 patients receiving these very costly but amazing medications, we have very little money left for every other child who doesn't have sickle cell. And so we might not have enough money to reimburse things like hearing aids or general care costs. And so at what point do we think about allocating these sort of scarce resources? When you think, if it's the right time, just think about like, why was there such this big outrage over the 2018 CRISPR editing these first 2 twins who scientist decided to provide HIV protection, because that sounds really noble. Why would we be upset about a scientist who's trying to help children not get HIV? But we think about sort of the scientific rationale for it. It was a gene, CCR5, if you want to Google it, which has very poor association between the mutations in CCR5 and protection against HIV. So there was, unlike sickle cell, which we really have a pretty good idea about what causes the disease. In that case, we didn't. There were some other impacts of that gene too. So we just want to talk about the science of the genetics, but also there's other pretty good ways to protect against HIV. Like there are other options available for those twins besides taking this this step to something that we didn't quite understand. Again, might be a little different than sickle cell, where our treatments are available, but not great. So just sort of thinking about the context of why don't we think that gene editing is the approach for every disease? I want to highlight at the end of my talk every time, really thinking about equity and how do we solve that.
My work is, again, more preclinical, and I worry less about that equity among the stem cell or among our cell lines. But I do think, when we think about preclinical, like true lab work, I think the questions that come up, and maybe you can speak to this more, but really becomes the embryonic work that has been at least started and talked about with the CRISPR technology. It's honestly a little bit out of my expertise. I truly only use, human-derived cell lines that essentially replicate what look like an ovarian cancer tumor looks like in a petri dish. And it's really used from a more exploratory sense to try to understand potential targets for new therapeutics without actually using, again, gene editing within an individual. But I do think there is a space for conversation around the ethics of preclinical work as well in the setting, particularly of work with embryos. And I'm sorry, I can't speak to that in a ton of detail because it's really outside of my expertise, but I don't know if you've, Curtis, have anything to say about that?
Yes. I don't know if this is the right time to talk about sort of germline editing of embryos. And I think they're just recognizing how there's been this big shift in sort of our approach to genetic technologies. When your parents were alive, maybe they were wee children like me. I think that's the appropriate age. In 1975 at the Asilomar Conference of Recombinant DNA, basically the takeaway message was these technologies are scary and everyone should stop. And then in the 90s, when we cloned Dolly, the takeaway message from that was these technologies are scary, we should stop. What I'm really impressed by now is that we don't say that. We say like, these technologies are powerful and we should really approach with caution and really think about why we would be using these in embryos. And I think the concern is always an equity one still, like who is going to have access to changing embryos. It's no different than anything else we talk about in medicine. There's equity issues throughout all of medicine. But when we think about technology like pre-implantation genetic diagnosis and IVF, we're still talking about who has access to these technologies, who has the right connections to know that they should be approaching them. And to be honest, the biggest thing that people are scared about, and I don't think this is the typical use case, but something that gets talked about a lot is that, are we going to be using these technologies to sort of choose perfect children? Certainly, I think most use cases are for really severe, debilitating diseases and for parents who want to have biological children that are genetically similar to them. And so this is, I think, the majority of the use cases. Families who say, I want a genetically similar child to me, and I want to make sure that they don't have sickle cell disease or cystic fibrosis, or pick a devastating disease of your choice. I think the conversations are always worried about, what about that next family who decides, I want to make sure that my child is at least 6 foot tall?
Yeah, thank you for that last point as well. I know the implications on who gets to decide what CRISPR-Cas9 should cover is a big ethical discussion. So I'll just ask one final question and then we'll move on to get in some audience questions, but what do you see in the future for CRISPR-Cas9 technology in your field, and how could it be implemented to essentially drive change in your places of work?
Well, I think for sickle cell, the future is now. So we are seeing some change in the treatment paradigm for these patients. And so if they're starting to have really severe complications and organ damage from the disease, we now have a new tool that we can offer them that we call it transformative therapy as opposed to curative therapy, because we don't have really long-term data on effects on organ function, because the clinical trials were all powered on pain reduction in these patients. But we do have this new tool, which we are able to offer theoretically most of these patients if they do have a problem. I think that in sickle cell, because it's a monogenic disorder that has an easily you're able to obtain the stem cells, you're able to edit the stem cells, you're able to put them back, and you have a protein which you can measure very easily to assess response. Like, it is kind of the prototypic disease that you would want to be treating with this. We already see that people are moving on from CRISPR-Cas9, right? So there are CRISPR-Cas12a studies, which is the one that we have open here, which is kind of a next generation version of the technology. There's base editing and prime editing, which are being used to swap single nucleotides. And so people are moving forward from a technological standpoint in order to try to get the best increase in hemoglobin and non-sickling hemoglobin possible. And then at the same time, we have to know what the long-term effects of this are. Anytime we edit stem cells, you can always have a spelling error. And in early lentiviral gene therapy trials, there were 4 people who developed AML, and 2 of them died from their AML. So optimizing the editing strategies to minimize off-target effects is going to be a really important research question that's coming up in the future.
I think all of the gene editing tools in our toolbox are so powerful and so exciting. The question is really, do we understand the off-target effects? Even thinking about gene replacement therapy, which has been around since the 90s, and it feels like such an old technology, but we know those individuals have such a significant increased risk for hepatic cellular carcinoma. So really thinking about these off-target effects, but we're going to get better at it. We're going to be able to improve the lives of some kids. And I think that's the really big issue is, and sorry, my pediatric bias, but I keep saying kids, all people. I guess adults are important too. We're going to improve the lives of all people. But really, I don't think we are, we don't have the same powerful toolbox to think about equity like we do the genetic technologies. And there's been some discussion around sort of reducing the amount of money that a single company can get per single drug. And we've seen ramifications from that. There was a very successful phase 3 clinical trial for a rare disease called GM2 gangliosidosis, where the company just said, we're not interested anymore, despite it being efficacious and kids going from being able to not walk to walk. That's a pretty powerful outcome. There just wasn't enough money. And so we have to figure out like how we balance, what is that powerful toolbox to figure out these issues?
I think in the GYN oncology world, as many of you may know, there is, a germline mutation, BRCA, which increases your risk for ovarian cancer specifically. And, I think that's the most natural path of progression in terms of targets within our practice and our realm of women's cancer care. I will say the work is all still very much preclinical and actually looking at, usually patients will have a deletion in the BRCA. So it's actually about knocking the gene back in and seeing improved treatment response, but again, at the cell line level. So not looking in patients yet. So I think, from an exploration standpoint, there's a lot we can do preclinically in terms of trying to identify new potential targets, and then kind of also using the germline mutations that we do know drive some of these cancer processes and potentially trying to target that. But again, it's at least at this point, and it's kind of out of our day-to-day practice because it's all preclinical. We have just initially tried this technology in BRCA mutated cell lines. So I think, you know, from at least an adult cancer perspective, at least for gynecologic cancers, like we have a ways to go. But it is an exciting technology that really allows like a different level of manipulation on like the preclinical translational side, and kind of allows for a whole different type of learning about a pathologic process. And so there's, I think, a lot to come.
Okay, thanks so much for that. I'll open it up now to any questions from the audience.
You were talking about one of the problems being accessibility and like not only cost, but also distance wise. So my question is, how could you foresee like this treatment being scaled to the point where A, it's either affordable or B, it's something you can get readily accessible?
Yeah, I think that at least from a sickle cell thalassemia standpoint, one of the leading reasons why it can only be delivered at certain centers is because this is an autologous ex vivo manipulated product, right? So we have to collect stem cells via apheresis. It has to be manufactured at a central manufacturing facility where the gene editing is actually taking place. And then we are giving myeloablative chemotherapy, which necessitates that they stay in a hospital for 4 to 6 weeks while they basically have no immune system and are waiting for it to recover. So that is not something that is really scalable. And that is going to be one of the major limitations. There is research being done to look at in vivo administration of these, but we don't have that technology yet. So that would potentially be one way that you could scale it, is if you were able to give it in vivo without needing to give myeloablation beforehand. But I think that we are a long way away from that. And then the second thing that is currently in research is monoclonal antibodies that would be non-chemotherapeutic agents that maybe target markers on stem cells to eradicate those stem cells. And so things like CD117 directed monoclonals potentially could eliminate the alkylator, which might improve the impact on fertility long term. But again, it's probably decades before we would be able to scale this.
Okay, anybody else or anybody on Zoom?
Yeah, what a great question for those of you on Zoom. I'm gonna phrase it. Tell me if I do a good job. The question is really, does someone think, I hope it wasn't me specifically, think that there is a difference between enhancing a human being, whether that's through some sort of genetic selection or genetic editing, versus restoring to the, how did you phrase it? The normal state, natural state? Yeah, so is there a difference? I think it's a great question. I don't think that Dr. Curtis Coughlin, should be the one to ever answer what we should decide what are the appropriate targets for genetic editing. And I don't think it should be you either. And I think it should be sort of this engagement with society to really think about it. But in general, people usually have thought that there's a difference between severe life-limiting diseases and those things that might improve one's subjective quality of life. Like I would love to not have to sleep at all at night. I'm so busy. It'd be great if I could make sure that I didn't need that anymore. But is that the same thing as like protecting against ovarian cancer or not dying from a childhood disease? But one of the hard things is, how do we have these conversations? Who are the people that we should really engage? Should it be society in general? I think it should. There's an interesting paper that just came out this month that's discussed how important that we engage with end users, which I think was the first time I've ever heard a family thinking about going through therapy being called the end user, but I think it makes sense. But making sure that we have this discussion about what we think is appropriate as a society. It's a little different than we think of most clinical ethics decisions in Western medicine. Most of the time, we really are emphasizing individual decision-making, right? Like, I don't have the same view of my children's quality of life that you might have of my children's quality of life, or and we don't sort of impose those decisions on each other, and we really value this individual decision-making. So I think it's hard for us in Western medicine to sort of come around that it's not individual decision-making. It's not, to me, making sure my daughter is 6 foot tall is very, very important, but like, what do we think as a society? In other words, I don't have a great answer, but I think you're right. We need a discourse about it and thinking of ways of how to really come together, think about what are the appropriate uses of technology. On I mentioned Western medicine and sort of questions about how we have these discourses around the world, and it's complicated. I'm in the middle of writing a book on genetic technologies with a bioethicist from Sweden, and we thought we're going to pull together colleagues from around the world and really talk about sort of the ethical approaches in genetic technology that are same and they're different, and how we can learn from each other. But there are some really significant, stark differences. We did this survey a year ago. So as of a year ago, the 98 countries that we surveyed about the use of gene editing, 78 of those countries had a law in place that says that there could be no gene editing used for sort of healthcare. So that's very different about what we're talking today. There have been large group global statements about sort of what we think are the right ethical principles to apply to gene editing. Recently, there was the International Heritable Human Genome Editing Conference. It just rolls off the tongue. But everyone at that conference sort of said similar things, that what we really need is a discourse around why we think this technology should be used. And a lot of the discussion was we have to have really good association between the fact that this causes a disease. There really should not be other ways that we can treat these diseases. Even if those ways are hard and difficult, there's still other ways to treat them. And we should really think about what role individual decision-making comes, despite it being a global conference. I was really interested on how much there was this discussion about individuals who really want to have genetically similar children. So there's definitely conversations globally. And when I say globally, that means those countries that show up, right? It's definitely not everyone, but it's a lot of work to sort of harmonize. And I don't believe there'll ever be complete harmonization.
Genetically similar children mean?
Ways to be a parent, right? So this is a term that people in my sort of like niche of ethics and genetics use, but like you can be a parent, you can be a gestational parent where you actually carry a child, you can be an adoptive parent, just recognizing there's a lot of ways to be a parent. And to some people, to be a parent, what they really want is a child who has the same DNA as them. They want to be a parent of a child that they are the sperm or egg donor to that child. But just recognizing that there's a lot of ways to be a parent, and just having genetically children is just one way.
There's a raised hand in the Zoom. James O'Brien, if you want to say your question.
Hi, can you hear me? Hello? We can hear you.
Oh, okay, good. Hi, yeah. I would like to introduce something about potential disease and what might be your comments on that. So, we're talking about sickle cell anemia or HIV, et cetera, where I don't think there's much dispute over whether those are diseases or not. And then we have the American College of Medical Genetics identification of about 81 mutations or genetic phenotypes that may predispose to disease, such as neurologic disease, heart disease, kidney disease, et cetera. And I guess my question is, what role do you see this perhaps playing in CRISPR technology in the future? Thank you.
My wife tells me I talk too much, so sorry, Katie, if you're listening. No, it's a great question. I think that as we are understanding the genetic contribution to diseases more and more, James, even if you think past the ACMG list, we think of all the other small genetic changes that sort of contribute to our risk of serious but common diseases, whether that's obesity or asthma or diabetes. And I think, personal opinion, that in the future, these technologies are really going to have a role to sort of improving health overall. But in order to think about that, we have to overcome so many limitations, like the fact that it is so hard to get treatment just for a really well-established severe disease. But as we learn more about genetic contributions to diseases and we have more tools to change them, I certainly think that the future looks bright.
Test. Okay. My question relates a little bit more to relating all of this, as you said, like communication of information and making these technologies more accessible, but less from the cost perspective and more towards the public education aspect. So informing people that, these treatments exist, and like we have seen a lot with like COVID and the pandemic, there being differences in like public opinion and scientific opinion. How do you foresee resolving that or informing that discussion regarding gene editing and therapy moving forward?
Yeah, I think that a lot of education, both from a provider and patient standpoint, is going to be needed. We have received a lot of referrals for curative therapy in patients who maybe the indication is not there. So like in a patient who has thalassemia but does not have a transfusion-dependent form of thalassemia, because a provider heard, hey, this is FDA approved now, we should get you this. So I think that there's going to be a lot of education that has to be provided to a provider. We've had the same thing. We've had referrals for patients with sickle cell disease who have really severe organ damage, which is not going to be reversed by the treatment, right? So if you wait till they're old enough and they already have end-stage renal disease, et cetera, you're not able to reverse that with the gene therapy. So managing those expectations is also important. And then we've also seen a lot of patients who come and are very, very interested because they hear about it on the news. And then they hear that they have to get chemotherapy and they're going to lose all their hair and they're going to have bad mouth ulcers and need to stay at the hospital for 6 weeks, and they are going to be infertile, and the conversation ends like as soon as I say infertile. And so, I think knowing that this is not just an operative surgical procedure for them, and that this is like a long process that is maybe going to take a year or more for them, is really important with expectation management. So I think increasingly that's going to fall to the referring providers, to their subspecialists who are making the referrals to gene therapy. And that's why kind of this information has to be disseminated from in the spoken wheel fashion from current treatment centers out to whatever the referral network is.
If necessary, I will always have a question. Lindsay, you really made me think about what is the difference between elucidating the effects of a gene at the level of the protein that it eventually generates versus, and then targeting that protein as the therapeutic target versus targeting the gene. Which I've always thought of as being, very different, but as I thought more about what you were saying, I'm not sure I see as much difference anymore. So I'm wondering if you can help me get back to a comfortable place in my brain where I think there is a clear difference between using genetic technologies to elucidate the effects of proteins and then doing what we always have done, which is target proteins in one way or another with medications versus targeting the gene per se.
Yeah, at least in my experience, it's part of the difference of it is like the totality of it, if that makes sense. And at least in our work, when we actually knock out using CRISPR, when we knock out our target, like the gene for our target protein, chromobox 2, cells just don't survive because it relies on a little bit of CBX2 in order to replicate and continue to grow. And so we see a complete absence. And when we look at our gene libraries in the setting of CRISPR, however, when you use a protein-based inhibitor, there, you can get a certain percentage of inhibition while still having enough expression of that chromobox 2 to allow the cells to continue to grow in some way. And I think that it also that gets to the off-target effects you can see with CRISPR where we don't know. And that's one of the risks even in the translational setting of using CRISPR technology is knowing exactly what the impact of each knockout may be. So that's kind of how I think about it. And the reality is that, or at least in our work to date, so many of these proteins and genes leading to these proteins have multiple jobs, and therefore you may not want to lose all of it. And so that's how I think about it. But I also, my work is pretty focal, in terms of these very specific drivers of high-grade serous carcinoma. But that's what we've seen, at least in the lab, in the difference between, knocking something down, knocking it out, and then inhibiting it with an actual inhibitor. I don't know if you guys have other thoughts.
They've tried different. So there's a medication that's approved by the FDA that blocks sickle hemoglobin polymerization, trying to get at it from that protein level. And we've just seen underwhelming clinical responses to that, which I think is why people have tried to do this. And then, again, this is more of a congenital disorder that is going to be lifelong. And so probably a one-time single infusion has certain potential benefits over needing to take something routinely.
Leaving in 2 days to go to a family conference and had a public health student do a survey of the families, as we're excited that we have 3 different preclinical medications that seem to have worked really well. A gene transfer therapy that's possibly one and done, and then these sort of chronic therapies, one using mRNA infusion and an ASO approach. And it's interesting, some of the families are very focused on, I want something that I would have to take every week or every 2 weeks, because if it doesn't make me feel good, if I'm worried about the side effects, I like the power to be able to stop it. So thinking about the previous question, sort of how do we meet families who might have some hesitancy about these one and done therapies versus something else? I think there's a reason that we should really be thinking about multiple approaches, not just because they might work differently, but also they might meet families where they need to be met.
To add something else to that, just with the carcinogenesis theory, at least with an ovarian cancer, it's often more than one hit that leads to the like progression of disease. Like I think if we knew that we could knock out a single gene and make it so that you would never get an ovarian cancer, like that would be really exciting and something to think about. But the reality is like even when we really reduce expression of something like chromovox 2, there are still other mutational pathways that would allow the cancer to develop. And so in that setting, the idea of inhibition across multiple potential pathways rather than just knocking out a single pathway, at least to date, has been how we've approached trying to think about novel therapeutics as like a in combination rather than a single hit, at least from our understanding of the pathogenesis of high-grade serous carcinoma.
Okay, so we have some really great questions coming in online that I want to make sure we get to. I'm going to start with the one that has the most upvotes. This is from Judy. And she says, more and more the medical community has advanced medical and technological advancements that are truly unaffordable to general society. And what is the justification for continuing research that patients can't afford unless they're in a clinical trial?
I would upvote that question too. In the rare disease space, in just this year, we've seen 4 very successful trials and the companies decide that it wasn't profitable for them and that they would both stop the drug manufacturer and fold as a company. And so you have these families in front of you who say, I feel worse that I tried this and it made me feel better and it gave me all of this hope and now it's not available at all. I wish I just never even knew about the possibility. I think that not enough attention is paid to like, how are we really going to make sure that we reach everyone? I think we talk about it in these rooms. All of us mentioned equity at some point, but I don't know what the solution is. But it is true that all of us as scientists, my lab as well, I'm guilty of this. I am working on curing diseases that even if it works, which I think it looks promising so far, I have no idea how a patient's actually going to be able to afford it or get it. And I think we need to spend more time and effort thinking about that. But I certainly don't have that answer.
Yeah, I mean, I think sometimes there's a benefit to showing proof in principle that something is possible. I think if we look at CAR T cell therapies for leukemias or lymphomas, you know, they are pricey, but they're more like $500,000 as opposed to $3 million. But the European Union has taken a very unique approach to this, and because they're a little bit more decentralized, Spain has elected to create their own CAR T cells nationally and to distribute those to their centers around the country. So that would essentially be akin to like nationalization of some of these things. They can't use the exact same construct that is patented and used by the drug companies that market them, but they use a similar construct with a slight tweak that then allows them to be able to provide a similar type therapy to their citizens. So that is one way that things have been done, at least in the CAR T realm.
Can you walk us through how you would approach a family in a conversation about sterilization? And specifically, I'm thinking about in a community that has been historically subjected to sterilization without consent, that these fears of research more broadly might enter in some of the anxieties that families bring when they come to consider this treatment? Thank you.
Yeah, so we take the approach that we are very upfront and honest with them about the infertility risks associated with it, that this is not 100%, but it is probably over 80% that they will be unable to naturally conceive a child on their own. For all of the clinical research trials, fertility preservation has been funded in the trial for participants in the clinical trial, but that is unfortunately not necessarily the case for standard of care And so the Children's Hospital uses philanthropic funds in order to pay for fertility preservation for these children. So either testicular or ovarian tissue cryopreservation or egg harvest. Unfortunately, that still only provides them with a finite amount of storage, which if you are saving ovarian tissue at, age 5 or 6, you'd have to pay storage fees for maybe 25 years before you're going to use that tissue. So it doesn't solve all of the problems. And we're just very honest with them about that. And we also talked to them about the fact that there is no guarantee that they would have, that they would be able to conceive naturally, even if they don't do this, right? Because no one is guaranteed the ability to conceive a child naturally or like without assistance. And we talk about the fact that there's lots of different ways to have families.
So there's sort of a related question online from Alexandra, and she's curious if there's any insight into potential legal barriers to studying CRISPR technology within reproductive health research in particular.
So the question is about the legal barriers within reproductive health research specifically.
Yeah, or any potential for that.
I don't know of, I just, I'm sorry, I don't know of, and I'm the closest to reproductive health research as an OBGYN. But not that I'm aware of. And, I do think that it's probably state dependent, just understanding like the limitations around stem cell and embryonic research at the state level. I don't know if you know any further.
Yeah, I mean, it's a great question because we've seen like complete bans on some of the research over time. And I hear that members of government make strange choices. So it's hard to know what things will be today versus tomorrow. But around the world, there certainly are very different limitations about what you can do in a research lab and in an embryo and a cell line. Most of the limitations are about implanting those genetically altered embryos, which there are lots and lots of regulations and limitations are in our country as well as others, but certainly it changes from country to country. Every position statement that has come out about CRISPR, everyone has done a very good job of being concerned about that possibility. And there is a section on every single statement that says we should not limit research into the use of CRISPR or any gene editing technology of embryos. I don't know that those scientific position statements are always what Congress uses to make their decisions, but certainly they're in every statement.
Sorry, we have time for one more question.
So kind of piggybacking off of what you just said, how do you engage your average voters / average individuals in this type of scientific conversation, which like can be very challenging and can include a lot of jargon a lot of the times? Like, how do you make that accessible to people who actually have the power to change who's in government, who's making these decisions?
Love the call to all of your colleagues in this room about how we all have a responsibility to do that to society, right? Those of us who are seniorish faculty members and those of you who are first-year medical students, like our responsibility to do that to our colleagues in general, so that they're aware of truths about science as well as impacting voting. So what a good call for everyone.
I would say that our community-based organizations that we partner with are very active from a political standpoint. I am not, as a state employee, I'm not, able to lobby or do anything like that, but our partner organizations are very vocal. And even, to get Medicaid to cover this, we had to pass a state law in order to form a carve-out for the inpatient administration of high-cost drugs. So we weren't able to offer any of these clinically until we were able to get the legislature to pass a carve-out so that this could be added to that carve-out from a funding standpoint. So it's going to be important.
Okay, so it's It's 1 p.m. right now, so we'll wrap the panel discussion there. If everyone can just join me in giving our wonderful panelists a round of applause. And if you have any follow-up questions, you may be able to just get it in quick while they sneak out the door.